series today, or this this session with an excellent group of colleagues. I'd like to start off by introducing them to you. So this again is a breast cancer prevention panel, and joining me today first virtually is Dr. Anna Cristina Sandoval Leon. She's a medical oncologist who specializes in the treatment of breast cancer, both invasive and non-invasive, recurrent and advanced breast cancer. She has expertise in the most advanced systemic therapies such as chemotherapy, hormonal therapy, and targeted therapy. And she works closely with each patient and the cancer care team to coordinate treatment across different disciplines and monitor a patient's overall health and outcome. She is heavily involved in our breast cancer prevention clinic here at Miami Cancer Institute, and she won't be with us live. We will be playing a pre-recorded session that Dr. Sandoval recorded for us, but she will be available to answer any questions that anyone has later by email if needed. And then next, it's my pleasure to introduce Dr. Katharine Lampen-Sachar from Diagnostic Radiology. She's a board-certified breast radiologist and an attending radiologist at Baptist Health Breast Center here at Miami Cancer Institute. She was previously an assistant professor of diagnostic radiology and an assistant attending of radiology, breast and body imaging at New York Presbyterian Hospital, Weill Cornell Medical Center, and she completed her fellowship at Memorial Sloan Kettering. She's quite accomplished, and we are very glad to have her here with us today. She's authored several articles in peer-reviewed medical journals and has given many lectures. And then last but not least, Berenice de la Mota. She's a clinical nutritionist and works with our patients here at Miami Cancer Institute's Cancer Patient Support Center. She earned her master's degree at FIU, where she developed an intrigue for the science of human behavior and nutrition, and she received specialized training in IBS from Monash University. She has a clinical experience in oncology, GI disorders, weight management, and wellness. So we are certainly happy to have all three of them with us today. And with that, I will ask the team to go ahead and play Dr. Sandoval's pre-recorded session. Okay, so I'm getting a message in the chat that there's no sound, and I thought it was just me, but maybe we can start it over again and see if we can get the sound to work.
Yes, thank you everyone for your patience. We will figure this technical difficulty out. Just one brief second, and thank you again for your patience.
Hi everyone. Hi everyone. Hi everyone. Hi everyone. And I'm gonna talk today about breast cancer. One of 8 women will develop breast cancer, so it's extremely important to know what you can do to keep the woman. Factors have been modified, and unfortunately, some of them are reliable. As we get older, we have higher risk of developing breast cancer. Patients can have the specific genetic mutations that affect 10% of breast cancer. Even though we cannot modify, we have mutations, and by doing that, we can develop. Patients that have future radiation on a high.
Did that sound better, Dr. Mahtani?
No, actually, there was
Okay.
quite a bit of feedback. So I I think Dr. Lampen had a great suggestion. Maybe while you're working out the sound issues on your side, maybe she can go first and then
Sure.
we can try it again.
Absolutely. Absolutely. Thank you, Dr. Lampen-Sachar.
Of course. I hope that everyone can hear me all right, and you can see my screen. It just says breast imaging 2022. So thank you very much for having me. I'm very happy to be participating in this. And I love talking about mammograms, perhaps too much, but I really, really do, because I think it's so important. And we are blessed that we have a whole month dedicated to getting women the appropriate screening that they need, but this really should extend throughout the whole year. So I always like to start off with this little anecdote. And I think the truth is that, yes, we are confusing everyone. And this easily could have been my mom sitting on the table asking me or her doctor about when she should be screened for breast cancer. So we are confusing everyone. So I hope by the end of my talk today, I will help to clear up some issues or questions that you may have. I think it's helpful though, and I'm a radiologist, so I love pictures. If we take a quick step back and just say, what are we talking about? So when we're talking about a mammogram, we're typically talking about, for the vast majority of patients, 2 views of each breast. We call these the cranial caudal view, which is the bottom part of my image. That's like a pancake view of the breast where we compress it from top to bottom. Or we're talking about something called an MLO view, which we're doing at an angle to the chest wall. So this is the way they actually look to us. And on the left side of the image is that cranial caudal view. And based upon the way that we position the breasts, I can tell when there's a finding, and I can sort of figure out on this particular view if it's towards the sternum, so centrally towards the inner part of the body, or towards the outer or lateral part of the body. And then using the MLO view on the right side, I can tell if something is located up towards the head or towards the foot. So that now that we all have like a basic understanding of visual on what we're talking about with mammograms, I think it's important that we start to delve into the major topic at hand. There are so many recommendations that currently exist out there for when women should be screened for breast cancer. So for the majority of this time, I'm really going to focus on average risk women. Who's an average risk woman? Well, that's the majority of people. That's where that statistic 1 in 8 women in the United States will develop breast cancer. That's the average risk woman, which translates to a 12% lifetime risk of breast cancer. So there are 3 main guidelines that exist out there. And hopefully by the end of this, I'll have suggested and hopefully convinced you all that the first set of guidelines is the way that we all should be going. So the guidelines that I really advocate for are the ones that are supported by the American College of Radiology, the Society of Breast Imaging, the American Society of Breast Surgeons, ACOG, which is the OBGYN Society, among many others. And you'll notice that all these people, these guidelines that are, all of these societies rather, are all made up of people that take care of women who have breast cancer. So the real experts. And what they recommend is that annual mammography for an average risk woman start on or around age 40, that it continue annually, and that it stop when there's a life expectancy of less than 5 years. So I'm a radiologist, so I just think it's helpful if we add a little bit of imaging to help, prove our point here. So in the top left-hand corner is unfortunately a nasty looking mass. It's spiculated is the terminology that we use. It almost looks like a star. And it has these tiny little microcalcifications coming out of it. That's indicated with this curved arrow. We did see this mass on ultrasound, and I describe this sometimes as almost like a Christmas tree appearance. When my eye sees a Christmas tree appearance, it's when I do start to get worried. In real radiology terms, we would call this an irregular hypoechoic shadowing mass. And then actually the right image is the way that it looked on MRI. And we can see that all patterns really look pretty similar. So unfortunately, this was a breast cancer in this patient that was detected off of screening mammography. I think it's also helpful if I help to clarify why it is exactly that I advocate for these recommendations. And there's a great website that I highly recommend called endtheconfusion.org, which really can help to answer a lot of questions related to screening. So we talked about this first one, a 1 in 8 risk of developing breast cancer for average risk women. And we have seen increased incidence of breast cancer, and it is a slow, steady progression. And the other thing that we've seen is that breast cancer incidence does increase with increasing age. And we've seen that it starts around age 40 is when we start to see this increased risk of breast cancer, and it progresses on. The other thing that we've noted is that there's no real scientific reason to delay screening until age 50. There's no reason why. It's not like we say, oh, you're 48, 49, you have no risk of developing breast cancer, but boom, you turn 50 and your risk explodes. Rather, it's a steady incline in terms of risk. And it's around age 40 that women start to develop this increased risk. And we've also seen that there are no parameters of screening that suddenly change at the age of 50. A lot of the other guidelines focus on starting at age 50 because they say that the risk of breast cancer for women less than 50 is negligible, and that's just not data driven. It's not true. And what we have found time and time again is that early detection saves lives and really it's when cancers are smallest and they're most likely to be curable. And we've also seen that even accounting for the latest and greatest in chemotherapy and surgery, it really is screening mammography that has really helped to lead to a huge mortality reduction secondary to breast cancer. And I'm going to touch on some of these other points in just a second. One final thing to note related to these statistics is that the harms of screening are negligible compared to breast cancer. The harms of screening are that a patient has to come back and get additional imaging and maybe get a biopsy that comes out being benign. But what we've seen are those patients that end up having that quote harm are actually the ones that become our most dedicated customers and come back year and year again. So here's just another nice example of a breast cancer that we saw and explaining sort of the importance of having prior exams. So the image on the left is the oldest exam and the image on the right is the newest exam, and we see a mass that progressively has developed. We never would have been able to have picked it up if we didn't have the patient's prior exams to compare it to. And then I sort of wanted to end this just by a few quick words on young breast cancer. We have seen that we've done tremendous work with decreasing mortality from breast cancer in women really in the past 20 years. But what has happened, unfortunately, is that young women who are too young, even for the most part, to get screening mammograms, we've stopped seeing a decline in breast cancer related mortality. And that's most likely due to increased numbers of later stage cancers in women who are less than 40. So if we were to wait until 50, I can't even imagine how many more women would die of breast cancer by waiting. And then here was a patient who was less than 40 that had a small irregular mass in their breast that was seen first with ultrasound that turned out to be a cancer. So in conclusion, I wanted to just end with this slide. And I think it's important that we emphasize that women of color are 72% more likely to be diagnosed with an invasive breast cancer, 58% more likely to be diagnosed with advanced disease, and 127% more likely to die from breast cancer all before the age of 50. So we have to enforce these guidelines of starting mammography at age 40. We have such a tremendous potential to save lives and to increase quality of life if we continue to do this. So thank you very much. And I know that we'll have time at the end for questions.
Yes, we will. Thank you for that excellent review. And I'm sure we're going to get a lot of great questions as we go on. So I think we're still having some technical issues sharing Dr. Sandoval's presentation. So we're going to switch the order a little bit and now turn to the very important topic of nutrition in breast cancer treatment and in general in terms of, reducing your risk of developing breast cancer. As I mentioned, we're very fortunate to have Berenice de la Mota join us. I'll turn over to her.
Thank you, Dr. Mahtani, and everyone for joining me today. I'm going to start sharing my screen. Can everyone see my screen?
Yeah, we can see it.
Okay, perfect. Okay. It's really wonderful connecting with all of you to discuss the important role of diet and lifestyle for breast cancer prevention. So I'm very excited to connect with you and discuss this topic. Again, I'm Berenice de la Mota. Let's see, next slide. So about 2 weeks ago, I just wanted to share with everyone that I had the opportunity of attending the Food and Nutrition Conference Expo, and that is a great opportunity to really stay abreast on the latest guidelines and connect with researchers and specialists in the field of nutrition, really in different areas of discipline, definitely, and including oncology. So today, a lot of the guidelines that I will really go over in this short presentation will highlight tips that I'd like to say are hot off the press. So we will highlight areas, namely, definitely navigate through the recommendations to improve long-term health and decrease cancer occurrence and recurrence. So here are the questions we should be asking ourselves when it comes to breast cancer protection. Number one, does a healthy diet make a difference for my prognosis? Does it make a difference before my diagnosis? How important is exercise? I've gained weight since my diagnosis. Does that even matter? Should I cut back on drinking alcohol? So these are really 4 areas that we will discuss and that are super important when we're discussing the continuum of breast cancer. So a healthy dietary pattern really plays a known important changeable risk factor role. Despite that, there is limited evidence for the decreased risk of breast cancer when it comes to a healthy diet. However, we do know, based on the latest guidelines, that a healthy dietary pattern is linked to improved overall survival from all causes of mortality after a breast cancer diagnosis. So that really means not just limited to mortality from breast cancer, but other chronic conditions like heart disease or diabetes, etc. However, I'd like to call this the danger zone. We do know that a Western dietary pattern increases the risk for breast cancer occurrence. And if it is linked to an improved overall survival from all causes of mortality when patients limit these types of food. So what is a Western dietary pattern? It's a diet high in processed meat, red meat, processed foods, high-fat dairy, refined grains, sugary foods, etc. And definitely associated with a higher risk of death from all causes of mortality. So what exactly is a healthy dietary pattern? When we discuss a healthy diet, we're definitely often referring to a plant-forward diet. So that really means choosing foods with plenty of fiber, nutrients, and plant compounds. So these help protect against cancer and other chronic conditions. As you see on this plate on the left here is the latest healthy plate released by the American Institute for Cancer Research. There's a lot of what we like to call non-starchy or low-carb veggies. So you definitely want at least half of your plate to have these foods items, because we like to call these plant-forward foods the soldiers of our cells. They have all these protective properties. When we're talking about a healthy diet, we're also referring to balance. So meals with a lean source of protein, such as chicken or fish. If we're talking about plant sources of protein, we're talking about green beans, lentils, or chickpeas. And we're also considering a healthy anti-inflammatory fat. So for instance, if we look on the left, if we were to drizzle a little bit of olive oil here, that would be our healthy anti-inflammatory fat. Or if we took a handful of almonds and added it to this dish, that can also be your anti-inflammatory fat. And last but not least, we often forget to be mindful when we're eating. So I often like to emphasize this with my patients. When you eat, you want to pay attention to hunger and fullness cues to really help your brain register that you are getting full, because it actually takes some time for our gut and our brain to communicate, and for the brain to say, hey, you're eating, I feel your gastric receptors stretching in the stomach. And so you want to give that process enough time, and also eating mindfully helps you not only enjoy the meal more, digest it better, but it prevents us from overeating. A healthy eating pattern limits or does not include red and processed meat, sugar sweetened beverages, and highly processed foods and refined grain products. So really, refined grain products are those items that have been stripped of their natural beneficial properties. So, cereal without any fiber, when that's always a clue. I skip the front part of a lot of food items. I go straight to the nutrition facts, because I like to say the proof is in the pudding when we can see that the item has at least 3 grams of fiber, that it is in fact a whole grain versus a refined grain. So when you're looking at your breads, pastas, cereals, it's a tip I like to share with you. So weight gain is a known big risk factor, and body weight in general, when it comes to the continuum of breast cancer outcomes. We really recognize that weight gain and body fatness before and after a diagnosis of breast cancer is associated with risk. After a breast cancer diagnosis, there is a higher risk for reoccurrence. Weight gain after breast cancer treatment may increase the production of estrogen. So that's one theory, actually, which increases the risk for breast cancer recurrence in some cases. Evidence shows that the inflammatory nature of the increased fat in our bodies contributes to an increased risk for cancer. So really reaching and keeping a healthy weight after breast cancer may help to reduce the risk for cancer recurrence. And it also, in other health conditions like heart disease and diabetes. So you're killing several birds with one stone here. If you need to lose weight, it is best that you make small, sustainable changes for slow, steady weight loss. We discourage our patients from extreme dieting changes and rapid weight loss, because those are unlikely to be sustainable and even can lead to more weight gain. And as we learn more about the role of weight gain and body fatness in research, I have to say what's interesting is that weight gain, particularly at this point after menopause, is where we really want to be careful, because that's where we see an association with breast cancer occurrence. So timing seems to be playing a role. There's different theories about the mechanism of action. So a lot of my patients, may even, we see it as a success if you can at least stop the trend of weight gain. Because even with 5 to 10% weight loss, we can see change in metabolic parameters, such as liver enzymes when they're elevated, which is a common side effect of hormonal therapy. So even maintaining weight, ideally we all like to lose weight, but sometimes depending on my patient, we just aim to stop the weight gain trend to help address this risk factor for the continuum of breast cancer. I cannot emphasize how important the role of physical activity is in breast cancer protection. Time and time again, we keep finding that being physically active is strongly and consistently linked to a lower risk of death from breast cancer and other causes. So decreasing physical activity after a diagnosis of breast cancer is actually linked with a higher risk of death from any cause. I encourage you to engage in regular physical activity with consideration of cancer diagnosis, stage of diagnosis, your health, treatment, symptoms, and side effects. If your medical provider has deemed it safe, the goal is to reach a minimum of 150 minutes to 300 minutes per week of moderate intensity exercise. So that basically means exercise which you can talk, but not sing. So examples include brisk walking or yoga, leisurely bicycling, etc. Or 75 to 150 minutes per week of vigorous intensity activity. Here you would have trouble talking or out of breath. And some examples can include running, swimming, singles, tennis, or a combo of the two intensities is also fine. And you definitely, if possible, want to include muscle strengthening activity 2 or more days per week. Preserving muscle mass or obtaining muscle plays a pivotal role. Examples include hand weights, exercise bands, and body weight activity, like push-ups or squats. And at the end of the day, we often emphasize find ways to sit less and move more. So, taking the stairs or scheduled breaks, lunch walk, make your lunch a walking break, find ways to move more. A lot of times my patients count their steps with a pedometer or a smart device, because we're starting to find over time that the non-activity exercise, it also plays a pivotal role in weight management. So we often forget that this is important too. So ideally, if we can work towards including exercise and ways to move more throughout the day, we can live a healthier lifestyle. And again, just highlighting those benefits of physical activity and how it plays a role in your quality of life. With or without a weight loss, physical activity has so many benefits. It helps reduce fatigue, the most common side effect of cancer treatment. It helps improve symptoms of depression and anxiety. It helps improve sleep. It can help maintain or improve physical function. It improves immune health, appetite, muscle strength, range of motion. So many benefits to incorporating physical activities in the best way that we can. If you're not physically active, you can start slowly and increase as tolerated. So really pay attention to your body. Some of my patients only start with a few 10 minutes per day of light exercise and build up. If you have not been physically active before, you definitely want to talk to your doctor before starting an exercise program and take it from there. And often a hot topic in my practice is alcohol. Alcohol is clearly linked to a risk of breast cancer occurrence. So the more alcohol someone drinks, the higher the risk, especially women, and specifically women, actually, that's where we see the link with breast cancer and alcohol. So definitely want to highlight that today. However, believe it or not, there's some inconsistent data among cancer survivors and the impact that drinking has in the cancer recurrence and survival. So it isn't actually clear for most cancer types. However, in practice, we continue to really emphasize that to reduce your risk for breast cancer recurrence, it is just best not to drink alcohol. Growing research has found that there's no safe level of alcohol consumption in terms of the risk for cancer. And some data shows that their cancer reoccurring rate is higher for women who have more than one alcoholic drink per day. Nonetheless, patients often ask, what can we do if we do it? Despite there not being a threshold identified, if you do drink, make sure to limit it to no more than 1 drink a day for women and 2 drink a day for men. So in a nutshell, the recommendations to improve long-term health and decrease recurrence involves weight management, diet quality, staying active, and avoiding and limiting alcohol. Thank you everyone for joining me today. It's been an honor to discuss this important topic with you.
Thank you, Berenice, and that was a wonderful presentation. We have a lot of questions coming through the chat, and we are going to get to those questions. Happy to report that we've worked out our technical issues with regards to the last presentation, Dr. Sandoval's, so we can go ahead and try again, and we'll still have time for questions.
Hi everyone, I'm Ana Sandoval. I'm one of the breast medical oncologists at the Miami Cancer Institute, and I'm gonna talk today about breast cancer prevention. 1 of 8 women will develop breast cancer, so it's extremely important to know what we can do to decrease our risk of developing breast cancer. But first, we need to know what are the risk factors. There are some risk factors that we can modify, but unfortunately some of them are non-modifiable, like our age. As we get older, we have higher risk of developing breast cancer. Patients can have specific genetic mutations, and 5 to 10% of breast cancers are due to a mutation. Even though we cannot modify, we can act if we have a mutation, and by doing that, we can decrease our risk. Patients that have history of chest wall irradiation are at higher risk. Patients that have history of breast biopsies, specifically or especially they had something called atypical hyperplasia, meaning a growth of cells that look abnormal, or something that we call lobular carcinoma in situ, that even though it has the word carcinoma, is not really considered a cancer, or LCIS. Both these lesions increase the risk of developing breast cancer. Patients with dense breasts are also at higher risk, and that's why now it's usually incorporated in the report of your mammogram, your breast density. Family history, patients that have a first, second, or third degree member with breast cancer are at an increased risk, and having menses before age 12 or late menopause after 55. Being of an Ashkenazi Jewish background also increases your risk, mainly because there is more risk of having specific mutations. There are some factors that are modifiable, so this is where we need to emphasize and make sometimes change in our behavior. So use of hormone replacement therapy of over 5 years, although this is now an area of controversy, but it's still the recommendation is try to avoid, and if you need it, try to use it for the least amount possible. obesity, and alcohol use. And I think these are the two main factors where we can work to decrease our risk. An age at first birth over 30 or no kids, this is, even though it's modifiable, I think it's really hard to modify at this moment. So using these risk factors, we can assess your risk. And it's recommended that every woman has a risk assessment at some point in their lives to see if they are they have higher risk of developing breast cancer, because the screening will be a little different in this population. So basically, these calculators incorporate the risk factors that I had already mentioned. They also incorporate specific risk factors like history of ovarian, family history of ovarian cancer or male breast cancer, because those patients have higher risk of having a specific genetic mutation. And based on these, they estimate, the Therapeutic estimates your lifetime risk of developing breast cancer. Anybody that has a lifetime risk of over 20% is considered high risk. The one problem with this calculator, and one of the limitations, is it can overestimate the risk in a specific population, like patients with these atypical lesions that I mentioned before, or lobular carcinoma in situ, and also in patients with dense breasts. So why is it important to know your lifetime risk? Because this will determine if you should be getting an MRI or not as part of your routine screening. So the American Cancer Society recommendations for MRI is anybody that has a lifetime risk of over 20 to 25%, basically using these type of calculators that have a lot of family history, like the Therapeutic. Patients with prior breast irradiation, and some carriers or some genetic mutations that increase your risk to more than 20%. There are some genetic mutations like BRCA1 and BRCA2 when we recommend to have a mastectomy prophylactically, but some patients will not have the procedure, and in those cases we will follow with MRIs. Another calculator that we use is called the Gale model, and I use this calculator mainly to determine which patients will benefit from chemo prevention, and I'll talk a little more about this afterwards. This is a smaller calculator. It only includes first-degree family members, so one of the limitations is that it can underestimate the risk, especially in women with a strong family history of breast cancer. Anybody that has a 5-year risk, so different from the other one that we were talking, that is lifetime risk, this one we look at the 5-year risk of over 1.7% is considered high risk and candidate for chemo prevention. Having said that, 1.7 seems to be a little low. So some practitioners, and I usually recommend chemo prevention if the risk is a little higher, like a 3% risk in the next 5 years. Or patients that have these atypical lesions, because they are the ones that benefit the most from chemo prevention. So what is chemo prevention? Chemo prevention, even though it has the word chemo, is not really chemotherapy, is a medication that is an endocrine therapy that helps reduce the risk of breast cancer. It has shown to reduce the incidence by up to 50 to 65% in high-risk women. And the U.S. Preventive Service Task Force recommend clinicians to discuss chemo prevention with our high-risk patients. Approximately 15% of women are high risk according to this model, the Gale model, but chemo prevention uptake is still very low. These are the 4 drugs that we can use for chemo prevention. If you're still not in menopause or you're premenopausal, tamoxifen is the only drug approved. These are what we call SERMs, or selective estrogen receptor modulators. Basically, they modulate how the estrogen works in your body. In the breast, they decrease the action of estrogen, and by doing that, it decreases the risk of developing breast cancer. Raloxifene is another one in this group of drugs. And then for postmenopausal women, raloxifene is an option, and the aromatase inhibitors, anastrozole and exemestane. The aromatase inhibitors, what they do is they decrease the production of estrogen in the peripheral tissues. So we have this study, Making Informed Choices on Incorporating Chemo Prevention into Care, or My Choice. This is only for patients that have these high-risk lesions like the typical hyperplasia or the lobular carcinoma in situ, because the studies have shown these are the patients that benefit the most for chemo prevention. This is basically a tool that was developed at the University of Columbia in New York to help patients make the decision regarding taking or not the medication. So patients will have access to educational videos where they describe what are these different lesions, is a typical hyperplasia or LCIS, and also they discuss the different drugs with the potential side effects. And after having all these modules, the patient can make the decision if they want to take or not the chemoprevention after having more education. This tool, what it really wants to see is if patients feel more comfortable with the decision, regardless if it is taking or not the medication. And I know we have our nutritionist today, but I really want to emphasize that diet and exercise is probably the most important thing to do to prevent breast cancer, and not only breast cancer, but other cancers. So these are the recommendations for the American Cancer Society. We should have a normal BMI. We should eat lots of fruits and vegetables. We should avoid red meat, processed meat, sugar, sweetened beverage, or processed food. Try not to eat red meat more than once a week. Avoid alcohol consumption, and engage in at least 2.4 hours per week of moderate physical activity. I really want to emphasize that exercise and diet can really improve outcomes and decrease the development of many cancers. And this is was just in the news a couple of months ago in August. There was a study that showed that almost half of the cancer deaths are attributable to risk factors. And the risk factors, the most common were alcohol, tobacco, and obesity. So it's really important that we exercise and that we eat healthy if we want to live longer. Finally, here you have some resources in case you want to learn more about what we talked today. And something I didn't mention is that it's important, if you have family history of breast cancer, to talk with your healthcare provider to see if you qualify for genetic testing, because even though it's only 5 to 10% of cancers are due to genetics, if you have a mutation like a BRCA1 or BRCA2, patients can have a risk up to 80%. So it's important to do the screenings and to consider sometimes procedures to decrease your risk. Thank you.
Okay. Well, as I mentioned, Dr. Sandoval couldn't be with us live today. That was a pre-recorded presentation that she kindly provided us to play today. But we can get her questions. If someone has a question for her, please put it in the chat and we'll make sure that she responds to you at a later date. So we have about 15 minutes left, and we have some great questions that have come through the chat. I'm glad to say that they're pretty well distributed in terms of, you know, who we would pose these questions to. So the first one I'll pose to Dr. Lampen-Sachar, which is when should women start doing self-exams?
I'm a huge advocate for starting actually towards the end of puberty and continuing on a monthly basis. It's really interesting that a few organizations have actually stopped recommending that women do their own clinical breast exams. And I just think it's faulty information. And I think we all anecdotally can talk about friends and family members that found their own breast cancers by doing clinical breast exams. So a general rule of thumb is while you are menstruating, that you be consistent. So typically, you can do it a few ways, but one easy way to do it is on a particular day of your cycle. So perhaps after you have finished menstruating, you then decide day 8 is going to be your consistent thing. And then I would recommend calendaring it and doing it every single 8th day of your cycle. Another way you can do it is you can say, I am always going to do it on the 1st of every month. And it works out about the same hormonally. But for me, that's my personal favorite. I calendar September 1st, October 1st.
Got it. Thank you for that great advice. I agree with you. You know, I can't tell you how many patients have come into my clinic and have said that, you know, they just went for a physical exam with their GYN or their primary, and, you know, they actually ended up finding the mass on their own. So paying attention to any changes in your breast self-exam is really extremely important. So Berenice, this question is for you, and I think this is something that we all struggle with as we walk through the aisles at Whole Foods and Publix. Should I buy organic fruits? Are they healthier? Oh, I think you're on mute.
I love this question. I was just saying, yes, excellent. So we have something called the Dirty Dozen, and I often, it's a list that you can easily Google by the Environmental Protection Agency. And I like to really go by that, but really the rule of thumb is if you're gonna eat the skin of, for example, an apple or the strawberries, or I like to eat the skin on my potato, if you can invest in organic, I would be selective to have it when you're having those items. However, if you're having, let's say a pineapple, great example, you don't have to get it organic. We don't see a significant, as of yet, I mean, we always have more to learn. We don't really, we see that as not a big impact if you're not eating the skin. So that's the main thing. If you're gonna eat the skin, I do recommend, if possible, to get the organic. If you're getting an orange, don't worry about it. If you're eating a blueberry, then invest in the organic, because organic is more expensive. So, you know, just be smart about your selection. However, I do also like to say, if you cannot, for some reason, you're running low on the budget, we find that it's still worse to avoid fruits and vegetables altogether because you cannot afford organic. Unfortunately, that's not an excuse. It's better to include them as they are, because there's not even enough data to support that the organic is gonna really make that big difference. We have more data promoting fruits and vegetables. So I also want to put that out there.
That's great advice. Okay, so another question from the radiology perspective. What's the difference between a screening mammogram versus a diagnostic mammogram? And then I'll just add to that, because I think from the perspective of breast imaging that's available, patients and even some physicians that are not in the oncology world get a little bit overwhelmed with understanding what the role of other modalities, including contrast enhanced mammography or breast MRI, PEM scans. There are so many, thermography, there's so many different modalities out there. So could you give us a quick rundown about the different breast cancer screening modalities?
So for the vast majority of women, a screening mammogram, which I showed you the 2 views of each breast, is what should be a routine annual event that has shown the greatest mortality reduction. That type of mammogram, a screening mammogram, is for women who have no complaints. If you have any breast-related complaints, like you feel a lump, what we call a palpable abnormality, nipple discharge, to name a few, then you probably should be having what's called a diagnostic mammogram. And with a diagnostic mammogram, we get those same views, but we typically will add on a few extra ones. And the benefit of having a diagnostic mammogram in that setting is then that the radiologist makes sure to go in and speak with the patient and maybe do a breast exam. So it offers just a little bit more information. We also will do that in women who previously had breast cancer. We like to do diagnostic mammograms in those women. So those are the 2 main ones. It's exactly the same technology, radiation, but pretty low dose. And then the other, big, most common one would be breast ultrasound. And Dr. Sandoval talked a little bit about it with related to dense breasts. It's a really helpful tool for women that have dense breasts. So the typical scenario is we'll have a woman who comes in for her mammogram and the patient has dense breasts. And so we'll add on that ultrasound because it offers us an extra look at the tissue that may be hard to see with mammogram. If a patient has any complaints, like they feel a lump, we'll also add on an ultrasound, because sometimes we may see a mass with mammogram, but then we have to figure out what's inside that mass. Is it a simple cyst just full of fluid, a pocket of fluid, or is it a solid mass? So it's a very helpful tool. Breast MRI is I would say, number 3 in terms of most common. It's a great tool. It's really sensitive. We see a ton of cancers. We find 2 and 3 millimeter cancers. We also find a lot of benign things too. So it's not for every patient. We use it for women that are higher risk of breast cancer. We'll use it all the time to help us find tiny cancers. We have a lot of data supporting its use. There are a lot of other uses of breast MRI, but just the other most common would be a patient that has a new diagnosis of breast cancer. We'll use it to help us define what's going on in that breast, and also to get another good look at the other breast, because we do find what we call contralateral cancers in, I think it's like 3 to 6% of patients. So those are the top three. Then we start to move into some of the less common ones. One that's like super quote sexy right now is contrast enhanced mammo. It uses the same technology as a mammogram, but you get an intravenous dose of contrast, the type of contrast that's used for a CT, a CAT scan. That certainly is developing, and I see a lot of utility in the upcoming years. The jury's still out, though, I have to say, on exactly which patients should have it. For now, from my perspective, I see tremendous use in women who maybe can't get an MRI. That would be the number one, use for it. We really have phased out of using some of the other modalities, such as PEM, and for the most part, those would be the top four. And then I just have to, one final note regarding thermography. It is not a scientific study. It is not an imaging study. There is no data, like at all. And I keep researching this, supporting its use as having any utility in diagnosing breast cancer. So we do get phone calls asking if we do thermography, and we are a hard no, because there is no data supporting it.
Thank you for saying that. I brought it up because as a medical oncologist, it's something that a lot of women come to me also and ask about. There's a lot of fear about radiation and receiving too much radiation for imaging studies. And we always talk about risk and benefit, especially when you have a breast cancer diagnosis and the limited amount of radiation that you would get from a mammogram, as opposed to the information that you get, especially when you've had a diagnosis, and the fact that thermography is not a validated way to screen or to follow a woman who has a breast cancer diagnosis. And so one other question that's come in, which is another one that I commonly get, and this one I'll let you tackle, Berenice. Is it true that soy products can increase the risk of developing breast cancer?
Okay, another great question. Yes, and very common. So interestingly enough, as where we are now in terms of the data, is that if you have moderate consumptions of soy, especially as a breast cancer survivor, that is now identified as 1 to 2 servings, so a little less than before. It's actually seen as a part of a healthy diet, and even some data suggest that it could decrease the risk for breast cancer recurrence. I will say that a lot of the studies that we do have are from Asia, and people in Asia, or women in Asia, start having soy products at a very young age. So that is a limiting factor here, because we cannot compare it to Western society, where all of a sudden, if you have a breast cancer and you start eating soy, it may not be the same effect. But it doesn't, we don't have data showing that it increases the risk for breast cancer. Again, so it can technically be included in a healthy diet and moderate serving size. So I hope that answers your question.
Yeah, and I would just add, that if you look at some of the numbers in terms of the incidence of breast cancer in Asia, whereas you point out there's a lot of soy consumption, it's actually lower than it is here in the US. And I think the difference there is that here in the States and in a Western diet, we consume an extraordinarily large amount of processed soy, right? Yeah. So anything that's in a wrapper packaged product has soy in it because it's a binder, right? And it's that processing of the soy which is thought to be harmful, as opposed to, the natural soy that might be in tofu or edamame or some whole food, right? Not something that is packaged in a product. And that's what I always tell my patients, that as long as you stick to real healthy fruits and vegetables and real food instead of packaged foods, you're probably okay when it comes to soy consumption. So we have a few minutes left, but we still have a lot of great questions coming through. What is the difference between tomosynthesis 3D versus a regular mammogram?
So a 3D mammogram, which is tomosynthesis, they're one and the same, is a relatively newer technology that has really taken the mammography world by storm in the last 10 years. And it offers us a better view of tissue because it's almost like it makes a teeny little movie for us. And we're able to see teeny little snippets, slices of breast tissue. And then it compiles it and we can kind of scroll back and forth. It's a great tool. And it's offered, I would say, in 80 to 90% of imaging practices throughout South Florida. So chances are if you're getting a mammogram, you are getting the 3D technology. It's fantastic, but I've heard a great analogy when comparing 3D mammograms, tomosynthesis, to just standard 2-dimensional. It's like comparing an iPhone 1 to what, I don't even know what iteration we're on now, an
13,
iPhone 13.
14.
iPhone 14. Yeah, it has a lot more functionality, but they're still both iPhones. So yes, it's newer and it is better, but both are very effective.
Mm-hmm. Great, thank you. So we have a couple of minutes left. Still a lot of great questions coming through. Are there any anti-inflammatory foods that can help with cancer treatment?
Yes, so it's an interesting, I'm glad you mentioned cancer treatment because I really do see it as a continuum of care, and recommendations can vary. So when you're undergoing cancer treatment, we look at the big picture, and we definitely, symptom management is really important. So we may tweak recommendations as needed. But if you're relatively okay, able to tolerate most foods during treatment, then you can already start including 2 to 3 servings of those dark green leafy vegetables, or what we like to call cruciferous veggies, which also includes cauliflower, kale, broccoli. If you can include that as part of your routine already, then I would say do it. And then we tweak those recommendations as needed during treatment, because we definitely need to prioritize staying healthy and managing those symptoms. So for example, if you have a lot of nausea or diarrhea, maybe you can tolerate a small portion cooked, or maybe we need to limit it for a couple days until you're yourself again, and then you can tolerate it on the good days. But really a lot of research is coming for those cruciferous veggies. So having them 2 to 3 times a day, which encompasses a lot of dark green leafy vegetables, is ideal. And then we're also seeing carotenoids pop up. So if you can have 5 to 6 servings a week of the orange and red primarily, but we also have spinach, food groups or fruit and veggie groups, there's some protection for breast cancer there as well. And they definitely have those anti-inflammatory nutrients. Can emphasize how much omega-3 is important too. So if you could have 1 to 2 servings of fatty fish for a week, for example, then you're meeting your needs there as well. If you're vegetarian, you can go for a supplement or flaxseed to get your omega-3s. Great.
Thank you for those suggestions. So we are actually at the top of the hour. We promised to finish exactly at 1 o'clock. I know we didn't get to all the questions. The team who's organized this event has hopefully dutifully copied down questions, and we can follow up with you all. Thank you all for attending this prevention panel. You know, as they say, an ounce of prevention is worth a pound of cure. So we hope that you have gotten some information that can help you going forward to reduce your risk of developing breast cancer, and to have a better understanding of the importance of diet, nutrition, and appropriate screening. So I'd like to conclude by thanking my co-panelists for your expertise today, and I wish you all a great afternoon.
Thank you.